I'm Dr. Raymond Douglas. I'm an orbital and oculoplastic surgeon practicing here in Los Angeles and Beverly Hills. And I'm sitting here with Dr. Babak Larian, who's a thyroid surgeon practicing also in Los Angeles and Beverly Hills, and we work together quite a bit. What we'd like to chat with you a bit today is thyroid treatment. And Dr. Larian is a professional surgeon for treating the thyroid. He's the expert. But what we'd also like to talk about is in relation to Graves' disease and the treatment using radioactive iodine versus thyroidectomy. I think that there's a lot of confusion as far as thyroid treatment. I don't know if you'd like to give your holistic approach to that treatment in general and how maybe patients, when they're first diagnosed, start off sometimes on medical treatment and how that may progress.
Right. Thank you very much. The first thing that has to be done is to control the thyroid hormone level being produced. And that can be done by using medications and anti-thyroid medications like tapazole and things of sorts to bring down the activity level of the thyroid gland so that you can decrease the thyroid hormone levels, because the thyroid hormone levels are going wild in these circumstances and affecting every organ in the body, causing increased metabolism, increased activity in the heart, rapid heart rate, and so on and so forth, all the other symptoms that come along. And so that's the first thing to control, is the symptoms caused by these increased hormone production. And generally every patient initially goes on medical treatment to see how they do with that. And a lot of patients do well. They respond well and are able to be controlled with the medications, but a proportion are not, and those patients are the ones who end up trying to decide which path to take, if they're going to use radioactive iodine or surgery, and what's most appropriate for them. And I think a lot of patients really get confused and have a hard time deciding between the two.
Yeah. No. Patients often present with me with moderate eye disease, and
Right.
they're from Graves' disease, and their eyes are bulging out, and they're not experiencing visual changes yet, but they have a significant amount of eye disease. And there's been a lot of data generated looking at whether they should have medical treatment, radioactive iodine, or thyroidectomy. What's kind of been your approach in thinking about that patient population?
I think in the population that come to you already where they have the eye disease, the surgery has been the mainstay, because that's the treatment option that helps stop the progression and helps the eye disease the most. Radioactive iodine, although it can slow down the thyroid function issues, in 15 to 20% of the patients actually makes the eye disease worse. So the population that's already having eye disease, I think surgery is really the best option for them to remove the thyroid.
Yeah, I tend to agree. My patients sometimes are resistant and worried about their surgery, or they're worried about their radiation of radioactive iodine. But the fact of the matter is that if they have no eye disease, radioactive iodine sometimes can be a very reasonable treatment, and you can often prevent any of the eye symptoms from occurring by adding steroids. But if they have moderate eye disease, if they already have disease where the eyes are bulging out and they really need thyroid control, thyroidectomy is a wonderful tool. We just published in JAMA last year showing that thyroidectomy was one of the key factors amongst 10 million patients that we studied in a very large cohort that prevented the development of eye disease. So I think that it does have its role. Many patients are extremely fearful about thyroidectomy. Maybe you can tell them a little bit about what goes into this surgery, because it really makes a big difference to have an expert like yourself take care of these patients.
Thank you. Thyroidectomy is actually a relatively simple surgery, except there's some nuances. There are two main things that we have to worry about when we're doing the surgery. First is finding the nerves that go to the voice box. So these nerves are called the recurrent laryngeal nerves because they come out of the brain, they go to the chest, and they recur, make a turn, come up and go to your voice box, right? And they usually are in pretty characteristic areas. So when you do the surgery, you can go in there and find them at the lowest point under the thyroid and track them upward to the area where they enter the voice box. At the same time, you can use a breathing tube that monitors the function of the vocal cord. And so as you get close to the nerve, the vocal cord monitor sets off, alerting you to being close to the nerve, or the nerve being pushed or tugged, or any movement around the nerve. So that's an added measure of safety that we have in protecting these nerves. The other organs that we have to be cautious with are the 4 parathyroid glands. These are tiny little glands, 4 of them, which sit usually behind the thyroid, 2 on each side. And We need only one of those four to function properly for us to have normal calcium control in our body. And the reason we have four, probably evolutionarily speaking, is because there's a lot of thyroid disease, a lot of tumors that occur in the thyroid, a lot of immune disorders that happen in the thyroid, and potentially can knock off one or two of these parathyroids. And so nature has designed us to have more than one or two to be able to outlive these possible things that can occur in the thyroid. And so having only one will do the job. So the job of the surgeon is to find these four parathyroids, try to preserve them, but not only them, but also the blood vessels that are feeding them. So research shows that surgeons that are expert at doing thyroid surgery, that do thyroid surgery on a regular basis, tend to have better ability to preserve the parathyroids and preserve the recurrent laryngeal nerves and decrease the complications. Now, this surgery is almost not an internal surgery. By that I mean, when you do the thyroid surgery, immediately after surgery, the patient's able to eat, talk, walk. There's no limitations like that. The only limitation is not doing anything to increase your blood pressure for 3 weeks, because during those 3 weeks, if you increase your blood pressure quickly, that can cause bleeding under the surface. So you can't lift anything heavy, you can't run up a flight of stairs. Taking it easy, but you can go for walks. So there's not a lot of limitations in that regards, and it's a relatively easy surgery to recover from. Now, a great majority of the Graves patients are on medications and trying to control the thyroid level. So they'll have to go through that after the surgery as well, starting on thyroid replacement therapy. And that may take a variable period of time. You know, some people it takes a few weeks to get adjustments, and some people it takes a few months till they get the most ideal thyroid hormone level.
Yeah. Most of my patients that have undergone thyroidectomies and have been dealing with fluctuations in their thyroid hormone for so long that it's such a welcome change to at least be able to dial in that thyroid hormone right after a thyroidectomy. There's no long 6-month waiting period before you have to get onto a relatively straightforward dosage of medicine that might have to be adjusted, but at least it's straightforward. Dr. Larian is very modest. He actually specializes just in thyroid, parathyroid. So you do tons of these cases each year. Many patients ask me, how big is this scar?
Right. Well, it all depends on the size of the thyroid. If the thyroid is not tremendously bigger than normal, then a 3-centimeter incision can take care of it. And a 3-centimeter incision is 1.25 inches, so not a big incision. And usually we can have it in a skin crease in the lower neck, which can easily be hidden in that area. And generally the skin of the neck and the face heal very well. You know, that's why most of us have made it through our teenage years and those acne years fairly unscathed. And this is the quality of the skin that's in this area. It's designed to heal well with minimized scar. The body has a different healing quality. The incisions on the body, on the arms, on the torso itself tend to form thicker scars. So the incisions in the thyroid generally heal very well and can be well hidden. Some patients who've had this disease for a long time will have bigger thyroids. And the bigger the thyroid, the bigger the incision has to be. But we do start usually with a 3-centimeter incision and see if we can divide the thyroid in half and address one side and take that one side through the smaller incision.
Yeah, the advantage of having an expert. For more information, take a look at our YouTube and websites, and I think, thank you so much.
My pleasure.